Hello everyone, how are you? I am Dr. Said Yasna. Today I will be teaching you a very brief intro of the shock. What is shock? What are the different types of shock? And we will study a Vaginet on the type of shock question. And then after reading the question, I will jump basically into the general types of shock, and I will overview every type briefly so that we can get an overview. And then I will jump into the answer, and I will explain it to you. And then after this, I will compare all the types of shock into a summarized table. I will try to do I will try to be fit within the 5 minute window period, but if it gets a little extended, don't worry. It will save your rest of the lifetime for every type of shock question you face during your exams or even in your real life. So let's jump into it. So these are our learning objectives. So we will learn today what is shock, different types, and its different presentations. So let's jump into the question. So a 68-year-old man arrives in the emergency department 2 hours after the onset of chest pain. He is diaphoretic, lethargic, and visibly depressed. These are the vitals. BP is low, heart rate is high, respiration is high, oxygen saturation is almost normal or below normal. On the exam, you can see the JVP distension is present, bilateral crackles are there, extremities are cold, pale, and mottled with weak pulses. The ECG reveals ST segment elevation in the leads B1, B4. I'm pretty sure that from this scenario, you have diagnosed what the patient has and what the patient has gone through. But let's see what the question asks us. Which of the following best characterizes this patient's hemodynamic profile? The question is not asking us what's the diagnosis. So what's the question is asking us? So look, we are given with the different parameters to diagnose what type of shock the patient had. And if we know what type of patient is, what type of shock the patient is suffering, we can pick from these what parameters of that shock would be. So let's jump into. So basically, before going into the types of shock, what is shock? Shock is basically when your body vital organs are not receiving enough blood, and when they are not receiving enough blood, they cannot receive nutrients from the blood, and when they cannot receive nutrients from the blood, they cannot perform their vital function. And if the organs cannot perform their vital functions, it can be life threatening for us to survive and function in our daily activities. Okay. So, and since every living thing needs energy to perform its activities. So, same like human body needs energy and its organs needs energy, and from where the energy comes to the organs via blood. So via the blood acts as a river to deliver the nutrients to the vital organs. So what are different type of shocks? The broad category is cardiogenic, hypovolemic, distributive, and obstructive shock. So, uh, these are so basically, uh, these are some of the causes. I have written some of the causes. I'm not explaining the causes. I'm just briefly reviewing. So these are the causes of cardiogenic shock. These are the causes of hypovolemic shock. These are the causes of obstructive shock, and these are the causes of distributive shock. So basically, distributive is of some types, and obstructive is also of some types. Distributive can be broadly kind of classified into septic and non-septic. Septic when there is some sort of infection, and non-septic when there is neurogenic shock, which is a type of distributive shock in which there is disturbance to the sympathetic nervous system and the body is unable to send neurological signals to the blood vessels and the organs. And anaphylactic when the blood vessels get dilated because of an allergic reaction, and these are the causes: urticaria, allergic explosion, and angioedema. In the obstructive shock, I personally divided into two types, type A and type B. The type A is embolism and pneumothorax, the type B is cardiac tamponade and atrial myxoma. Why I divided it into two types, you will get it to know in a while. Basically, so what happened in the cardiogenic shock? What's the mechanism? In the cardiogenic shock, heart is basically, to summarize all these shocks and to understand these shocks easily, just listen this example simply. It's just like you all know that you have a motor pump to pump the water into the roof tank. So the pipes that are taking the blood and the rooftop where the blood is going. The rooftop is the heart, the pipes are the blood vessels, and the motor is basically the pumping of the blood vessel, the contraction of the blood vessels, which is by the signal from the brain by the nervous system. Okay, and the blood is flowing to the pipes and it's going into the rooftop, which is the heart. So what happens is the cardiogenic shock. In the cardiogenic shock, the heart is not able to function its normal activity. So the problem is in the roof tank. The problem is not into the pipes. The blood in the body is okay. The pipes that is the blood vessels that are taking the blood are okay, and the conducting system of the body, which is the neurons, is also okay. So the problem only in the rooftop, which is the heart. The heart is not able to pump the blood, which is coming from the lower body system and all the organs into the heart, and the heart is not able to pump that blood away. All right, this is the problem. And in the hypovolemic shock, there is volume loss, there is blood loss. The pipes are receiving less blood, less water is going through the pipes into the rooftop. So there is issue with the volume loss, the blood loss. In the obstructive shock, there is some sort of obstruction in the pipes or in the rooftop. That's why the water is not coming into the rooftop adequately. Either the pipes are blocked, either any there is any blockage in the pathway from the pipes up to the rooftop. Okay, and in the distributive shock, in the sepsis, there is infection. And when the infection happens, there is inflammation in the body. And when there is inflammation in the body, the vessels get vasodilated, the pipes get dilated, and the blood or the water gets pooled up in the water pipes, and it's not going into the rooftop adequately. And in the neurogenic shock, which is the subtype of distributive shock, the nervous system, the contracting force is not acting good. So that's why the blood is unable to go into the rooftop, the water is unable to go to the rooftop, which is the heart. So this is the basically overall summary. So before jumping into the answer, I will go into the basically the comparison table of some of the values, and then you will be able to jump back to the answer. So let's skip the answer first. So now in this, so basically these are some of the values: central venous pressure, pulmonary capillary wedge pressure, cardiac output, TPR, total peripheral resistance, or SVR, systemic vascular resistance, skin changes, and there are some classical clues of each of the shock. I know the time is exceeding, but this is very crucial topic, and I want you all to learn this once for all, and you don't need any further revision of this topic after listening this, inshallah. So to understand these values changes, first basically shortly tell me to you what are these values, and then we will get to know how these values changes. So what is CVP? The central venous pressure, the pressure in our veins, the central vein, the superior vena cava, the inferior vena cava. And where does that pressure came from? The blood that we are receiving in the form of venous return. This is central venous pressure. I know some books will confuse this, and you will see that uh, somewhere that central venous pressure will be written alongside of pulmonary capillary blood pressure in the same column, but they are not. There are some changes in each type of shock. You have to know this thing very carefully. These are not exact same things. What is pulmonary capillary blood pressure? It's the pressure which is present in the pulmonary capillaries, right atrium, right ventricular, pulmonary artery, pulmonary capillary, pulmonary vein, and then there is left atrium. So the pressure in the pulmonary capillaries is the pulmonary capillary wedge pressure, which is measured by a wedge, and it reflects the pressure in the left atrium because it's closest to the left atrium. Pulmonary capillaries are closer to the left atrium. So pulmonary capillary wedge pressure is the pressure in the pulmonary capillary. Central venous pressure is the pressure in the vein, which is behind the right atrium, in the superior vena cava or the inferior vena cava. So that's why these two values will be same in some type of shock and they will differ in other types of shock. Cardiac output, you already know, I don't need to explain this. SVR, you know that this is the basically resistance in the arteries when the blood leaves the heart in the aorta and in the further branches of the aorta. The pressure in those, the resistance in those is the TPR, total peripheral resistance or systemic vascular resistance. The skin changes, I will explain that in some type of shock, skin will be cold because the blood is not going into the skin adequately. In some type of shock, the skin will be warm because more blood is going there. And these classical clues, you can just read it by yourself because I don't want to explain this a lot. So let's first jump into the cardiogenic shock. So uh, what happens in the what happens in the cardiogenic shock? So what happened? What I told you that in the cardiogenic shock, the rooftop, the heart is the main cause which is defective. Heart is not strong enough to pump or push out the blood it's receiving. The tank is not good enough to receive the water coming from the pipes. So when the heart is not good enough, when the heart is unable to push the blood which he is receiving from the veins, so what happened to the central venous pressure? The central venous pressure would be high because there is a lot of blood in the right atrium, right ventricular, and heart is not able to pump it out. So all the blood is present in the heart. So when all the present pressure in the heart, so when there is a lot of blood in the heart is fluffy, the heart is full a lot, which is creating a backward pressure. So what will happen to the CVP? It will be raised. Okay. Oh, why am I writing, please? Okay. So let's go into the pulmonary capillary wedge pressure. What will happen into the pulmonary capillary wedge pressure? If there is any, listen this statement, if there is any issue with the heart, either it's ventricles, either it's atria, either it's arrhythmias, either it's heart failure, either there is valvular issues, pulmonary capillary wedge pressure will be raised. Why? Because what I told you, the pulmonary capillary wedge pressure is the pressure in the pulmonary capillaries. If the heart is not able to pump out the blood, if the blood is not going into the aorta from left ventricle, all the blood is backed up in the heart, and all that blood is present where also in the pulmonary capillaries, and the pressure will be in the pulmonary capillary will be increased. So what happened to the PCW? It will also be raised. And what will happen to the cardiac output? If the heart is not pumping out blood, it will be obviously decreased. And what will happen into the TPR? The TPR, what will happen? When the heart is not functioning, the blood is not going to the vital organs. So what will our body try to compensate? The body will try that most of the blood go into the peripheral organs because organs need blood to survive. And when the blood is not going into the organs, the cardiac output is low, the body will try to increase the force to provide blood to the vital organs. So heart is not functioning. Body, what body does? It constrict the vessels, it constrict the pipes. When the pipes are constricted, the water flushes out with more force. So it constricts the vessels to push the remaining blood, to push the less blood towards the vital organs so that they can get some of the oxygen from the blood. So the SVR will increase. And what will happen to the skin? The less blood is going out, heart is pumping less out blood, so the skin will be cold. You will feel, and you will, when you will touch the patient, the peripheries, the arms, the hands will be feel out cold. Okay. So, and what will happen to now we'll talk about the hypovolemic shock. Now, what will happen in the hypovolemic shock? In the hypovolemic shock, the problem is there is less volume of the blood in the body. There is blood loss from the body, less water in the pipes. So, what happens? What will happen to the central venous pressure? What was central venous pressure? It was the pressure inside the veins. It was the water inside the veins. So, in this that quantity is less. So what will happen to the CVP? It will be decrease. And when there is less blood in the body, less blood going to the pulmonary capillary and the heart. And when there is less blood going to the pulmonary capillary and the heart, the pressure would be obviously decreased. And same, the cardiac, what will happen to the cardiac output if there is less blood? Obviously, it will be decrease. And what the body will try? It will try to push the remaining, the less blood to the organs. It will constrict the blood. So what happened to the TPR? It would be raised as a compensation. And what happened to the skin? The skin would obviously be, C stands for cold, because there is less blood. Now let's jump into the septic shock. Septic shock had two categories based on the causes. One is sepsis or anaphylaxis, and one is neurogenic, in which there is neurons issue. So what's first jump into the sepsis? What happens in the sepsis? There is infection, there is inflammation, and when there is inflammation, the infection, the body gets more warmer. There is vasodilation in the body because of the infection. So initially, what happened in the infection? Heart tried to compensate. There is no issue with the heart. There is no issue with the vessels. There is no issue with the contraction force. Only there is infection in the body, and in the infection, all the metabolism of the body gets increased. There is fever. There is tachycardia. There is increased heart rate. The body tried to increase its activity to overcome the infection. So the cardiac output initially gets increased. So what happened to the central venous pressure in the sepsis? In the sepsis, so the in the sepsis, basically the central venous pressure is mostly normal because there is no blood loss, there is no issue with the heart. To central venous pressure doesn't change. The pulmonary capillary wedge pressure, the pulmonary capillary wedge pressure is almost normal, or it slightly gets decreased. Why? Because there is some vasodilation, and when there is some vasodilation, there is slight, the pressure gets decreased, the vessels, pulmonary capillaries gets vasodilated, and the pressure slightly gets decreased. What happens to the cardiac output? I said that it gets increased early on it gets increased, and in the latter stage it gets decreased, because heart can only increase the cardiac output shortly, and then the later on the heart gets fatigued and cardiac output gets finally decreased because it's a normal physiological action. And in the what happened to the TPR? When I said that the vessels gets dilated, and the vessel gets dilated, the pressure in them gets decreased. So the resistance get decreased. And what happens to the skin? The vessels are dilated, and when these vessels are dilated, more blood is pulled up in the skin, more blood is pulled up in the vessels, more water is there in the pipes. The pipes are not emptying up, so the skin would be warm. And what happens in the neurogenic shock? This is also a type of septic shock, just difference of the cause. In this, the central nervous system sending of the nerve signals is affected only. So what happens to the CVP? It's almost normal or slightly gets decreased because the blood will be pulled up in the vessels, because vessels are not receiving the signals to contract, and when vessels are not receiving the signals to contract, the vessels will dilate, blood will pull up in the vessels. But here there is no infection, and the pulmonary capillary wedge pressure slightly gets decreased because the vessels are dilated, less blood is going as compared to the normal. The cardiac output is decreased because there is no infection, heart is receiving less blood. What happens to the TPR? Vessels are dilated, there is less resistance, and the TPR will get decreased. What happened to the skin? It would be warm because there is more blood pulled up in the vessels. Now, let's jump into the obstructive shock. I personally divided this obstructive shock into two types, type A and type B, based on the causes. There is a reason. First, jump to the common causes, which is embolism and tension pneumothorax. What happens in the embolism? In the obstructive shock, you know that there is some sort of obstruction in the pathway. There is no issue with the heart. There is some sort of obstruction there. In the pulmonary embolism, there is the embolus. And in the tension pneumothorax, the lungs are collapsed. So the pathway for the blood gets narrowed and the pathway is feeling some sort of obstruction. There is some sort of bumps on the road. There is obstruction on the road. So why divided into two types? I will tell you when I will get to the pulmonary capillary wedge pressure. Okay, so what happened in the pulmonary obstructive shock? When there is obstruction, blood is not going forward in the heart. There would be backup of the pressure, backup of the blood to the veins. The pressure in the veins will get increased because there is obstruction to the forward flow of the blood. So what happens to the central venous pressure? It will be increased. And and uh, again in the type A as well. And in the type A, I put two causes which are tamponade and atrial myxoma. As far as now, in both type A and type B, the causes are that which are creating obstruction. In the cardiac tamponade, there is also obstruction. Heart is not able to relax completely because there is tamponade. There is blood in the pericardial cavity. So both, so as far as now, in the both types, the central venous pressure would be raised. Now, just for a moment, skip this PCWP. I will explain it later. What happened to the cardiac output in both type of shocks? When there is obstruction, the blood is not moving out completely. The cardiac output will get decreased in both types. And what will happen to the TPR? The TPR, what will happen to the TPR? The body will try to compensate. There is no issue with the vessels. There is no neurological failure. The body will try to constrict the vessel to send the remaining scant amount of the blood to the organs. So the SVR will get increased. And when there is more TPR, the vessels are constricted. Less blood is going to the peripheral organs. The skin would be cold. Now let's jump to the pulmonary capillary wedge pressure. What will happen to it? So if you see in the type A, what are the causes? These are cardiac tamponade. These are cardiac myxomas. What I told you previously, whenever there is an issue with the heart, PCW will always go high. Why? Because in a tamponade, heart is not relaxing completely, and there is would be the backup of the blood. When there is a lot of blood coming, heart is unable to relax more. It will increase more pressure, more backup pressure. In the atrial myxoma, there is left atrial myxoma, and the blood is not able to come from left atrium to the left ventricle. That would lead to backup of the pressure, and it would increase the PCWP. So that's easy, that's complete. Now, what students mostly unable to understand why PCW increased in type A type of obstructive shocks and PCW gets decreased in type B of obstructive shocks. Why? Most of the books will write only that PCWP is either increase or in decrease in obstructive shock, but it's not. It's the cause of the obstructive shock that will decide whether the PCP will go up or whether the PCP will go down. As I told you, in the type A, the causes are cardiac one. Whenever the cause is cardiac one, PCWP will always 110% go up. In the type B, if you see, there is an issue with the lung problem. There is embolus in the lungs. There is collapse of the lungs in the pneumothorax. And when there is the collapse of the lungs, pulmonary capillaries are not affected. Look, pulmonary capillaries are here. The lungs are here. Pulmonary capillaries are here, the lungs are here, and the heart, left atrium, and the left ventricle was there. So whenever there was a tamponade or atrial myxoma, it was increasing pressure here to the pulmonary capillary. Here are the lungs. If the lung is collapsed, if there is embolus here, the blood is unable to go from here up to here. Here is the pulmonary capillary. So when the blood is not able to or when the less blood is going from the lungs, maybe because the lungs are collapsed or there is the embolus, less blood is going from lungs to the pulmonary capillaries. So less blood is going here to the pulmonary capillaries, and the pressure in the pulmonary capillaries will be obviously decreased. That's why the PCP is decreased here, and this is the most critical feature of distincting obstructive shock causes because most of the scenarios you will jump straightly to the type of obstructive shock, but in the options they would be asking you about the cause of the shock. maybe they would be asking you about a tamponade, where maybe they would be asking you to put to choose the pneumothorax values. So if the diagnosis was a pneumothorax, you cannot pick these type of values because in the pneumothorax PCP would be decreased, so you have to choose these type of options. Now let's jump back. Hope so now you will clear about all types of shock and you will be able to select correct choices there. Now let's jump back to our question and try to answer that, and then we will see the answer slide. So I'm really sorry these are appearing on over here. Sorry about that, but let's see. So, uh, yeah, okay. So let me just first quickly remove these. Just give me a second. Just give me a second. Okay, perfect. So, so let's see this. I will highlight some of the important points here. So first of all, you will see the age of the patient, gender of the patient, 2 hours, it's acute situation. What's the main complaint? Chest pain. So you will see that vitals. BP is, so what's happened to the BP? BP is low. Cardiac output, heart rate is up. Respiratory rate is up. Saturation is low, low normal. GAVP distension present. Crackles. What are extremities? Extremities are cold, weak pulses. So, and you can see here ECG. ECG is depicting MI. So, what is MI? MI is related to what? The cardiac problem. And as you can see, as we discussed in the cardiac problem, what happens to the central venous pressure? It's go up. What happened to the PCW? It goes up. What happened to the cardiac output? Is go down. And what happened to the extremities? They are cold. What happens to the, and yes, obviously there will be JVP distension as well. So now let's jump to, first of all, clear me these things, and yeah, now jump back to the answer. Hope so you guys now can pick it up. So what would be the answer in the MI situation? The preload would be low or high? Yes, the preload would be high. So can this be our option? No, A cannot be our answer. And now, what happens to the preload I said? It's high or low? High, because the heart is the issue. The rooftop is the issue. Pressure would be high up. So can C says low preload. Can this would be our answer? Absolutely not. And now we are left with, so this is the thing basically. First, you have to rule out all the options to get back to the correct option. So now B says preload high. Yes, it should be. D says preload high. Yes, it should be. What happens to the cardiac output in the MI shock? Low. It says low. It says low. What happened to the TPR? The body tried to compensate it. TPR gets raised. TPR gets raised. So now both options are looking same. Now we are left with confusions. What to choose? B or D? But D says muffled heart sounds and pulse paradoxes. So these are the features of which type of shock? Muffled heart sound and pulses paradoxes? Yes, cardiac tamponade. But whether that question was of tamponade or MI? MI, correct. Why not tamponade? There was no mention of muscle heart sound or pulses paradoxes in the scenario. They are asking you to differentiate MI and heart, and moreover, the ECG. ECG was of MI. So this is MI, and the D option was about cardiac tamponade. So our answer would be B. We can check the answer as well. Yeah, so you can see correct answer is B. The preload would be high, cardiac output would be low, TPR would be high. You can study this as well. So this line, remember this, cardiogenic, just a second, remember this line. Yeah. Cardiogenic shock is the only shock where preload is high and cardiac output is low. But I want to tell you one thing. The obstructive shock that I told you about type A ones, those are also in this category. In the obstructive shock, the cardiac output, in the obstructive shock type A of cardiac tamponade and related myxomas, the cardiac output is low and the preload would be higher. So remember this, don't just jump in by seeing this type of things that, oh yeah, the preload would be high and the cardiac output would be low. So obviously this would only be a cardiogenic shock. It can be of type A obstructive shock. So so, so yeah, thank you very much from my side. I know the video is a bit longer. I was given the time of 5 minutes, but this topic was very crucial. I wanted to dedicate my time and showing my skills and dedicatedly wanted you to learn something from me that could help you and me as well to save patients in our present lives, in our hospitals, in our environment, because this topic is very important for every type of medicine subject. So hope you like this video and we would meet again. And thank you very much from my side. Allah Hafiz.